you very much, Dr. Braveheart. Next, I'd like to introduce Dr. Ethan Nebelkopf. He is the Director of Behavioral Health for the Family and Child Guidance Clinic of the Native American Health Center in Oakland and San Francisco. Dr. Nebelkopf has worked in nonprofits for over 40 years. He's the principal investigator of Urban Trails, a project to implement a system of care for Native American children and their families. He also leads One With All, which is a prevention program for urban Native Americans in Northern California. In 2007, he received the Award of Excellence for dedication to and development of integrated HIV/AIDS prevention programs, substance abuse prevention and treatment programs, and mental health services for Native Americans from the Substance Abuse and Mental Health Services Administration. In 2008, Dr. Nebelkopf was awarded a Certificate of Special Congressional Recognition for outstanding and invaluable service to the community. Welcome, Dr. Nebelkopf.
Well, good morning, everybody. I'm just really proud to be here. It's a great honor. I met Maria at a CSAC conference about 10 years ago. And it was called there was a Native American cluster. All the Native American programs that were funded by CSAT at that time got together. And that's where I heard my first presentation about historical trauma. And there was one, she mentioned today visiting about the Holocaust Museum, you know. And I'm Jewish, and I remember visiting the Holocaust Museum in Washington, D.C., and it was very painful, it was very depressing. So I kind of want to acknowledge the great work that she's done. I'd also like to acknowledge Martin Wakazu, who is my boss, CEO of the Native American Health Centers in Oakland and San Francisco. Also Helen Wakazu, CEO of the Friendship House Association of American Indians in San Francisco and Oakland. Are you hearing me without the microphone? Okay, good. Yeah, I'll get to. No clip on. I'll just carry this. Okay. And also the board of directors who keep our agencies open. Also, I'd like to acknowledge Jim Sorensen for organizing, and his staff for organizing this conference. I knew Jim 25 years ago. We worked on several projects before I was working with the Native community. Now representing Jim, the Clinical Trials Network, the California-Arizona node. We had a meeting, a half-day meeting several months ago, and we really discussed in depth, our staff and his staff, about the issues, research issues with Native Americans. We found out that there was a lot of misuse of research with Native American populations, and this was a critical concern. And as we went deeper into these issues, how to bridge the gap between the research, the Western science method, and indigenous model, we found the gap widening as we got deeper into the chasm. And then a couple of months later or so, Jim said, we're having a conference, you know, to bring researchers and natives together. We're going to focus on historical trauma. So I said, wow, that's a great way to begin to bridge this gap. I'd also like to acknowledge Tony Cervantes from the California Department of Alcohol and Drugs, who's been an ally for many, many years. And also the staff of present and former staff of Family and Child Guidance Clinic and Native American Health Center and the Friendship House. Raise your hands, because we have a good presence. It's just fantastic. There's so much love with myself and the people who we work with in these past 10 years. I'd like to especially acknowledge Nelson Jim and Michelle Moss, who have worked with me for many, many years and who will be presenting later on today. And I'd also like to acknowledge two women who have worked with me for 11 years, Janet King and Violet Lundberg. Janet is our community organizer, and Violet's our clinic director. So give them all a big hand. Okay, I'm an ally. I say I'm Jewish. I'm not Native. I'm an ally. I learned the word ally maybe from Theda or her mom, Betty Cooper. I've been working Native programs about 15 years, and somehow I didn't know much about Native people, but I got into it. I got into it through a series of circumstances. And I've worked at the Native American Health Center, Family and Child Guidance Clinic for 11 years. And this is the most creative work that I've done in my life. I've worked in alcohol and drug field, but working with Native people has been very rewarding. And the things that I have learned personally is how do you work with Native people? What's the magic? What's the secret? What's the formula? What's the formula for cultural competency? There's no formula, you know. What it comes down to, it was like respect, treat people with respect. Comes down to never turn down a meal, okay, you know. Have a sense of humor, you know, because there's a lot of humor in this community, a lot of pain, a lot of humor, and finally just being my authentic self, being who I am, not pretending to be someone who I'm not. So basically that's the bottom line of what I'm doing. I'll show you some slides and talk. The first series of slides are data, numbers, which is kind of expected in current PowerPoint presentations. Family Child Guidance Clinic, founded in 1972. Medical, dental, HIV, AIDS care, Family Child Guidance Clinic. We have mental health, substance abuse, HIV, AIDS, and youth services. We have offices in San Francisco and Oakland. Partnership. We're partners with the Friendship House Association of American Indians, an 80-bed state-of-the-art facility in San Francisco, residential substance abuse, and a small house in Oakland, used to be the Family Healing Center, that's called the American Indian Lodge for women and children substance abusers. Service profile, the numbers, we've been collecting data for 11 years. We have a lot of data. And this is a snapshot of our service profile. In April, ongoing caseload of 116 people, co-occurring disorders, about 40%. It ranges 40 to 60%. It really depends on how clever your diagnostician is. And HIV/AIDS, we have an AIDS department in our San Francisco clinic that have 45 HIV-positive Native Americans. This is unduplicated visits. The two data sort that are, when you look at the whole picture, 1,000 unduplicated clients come to our clinics each year. And we had over 7,000 client visits, which breaks down to 20 a day in Oakland, 10 a day in San Francisco. General categories of service, case management, talking circles, 38%, which is cultural event, some family services, and a lot of individual counseling. This is a pyramid model of levels of treatment, or dosage is what they call it these days, dosage. So your broadest level of treatment is your community outreach, cultural events, Thanksgiving celebrations, Christmas, families in recovery celebration, gathering of the lodges. These are huge community events where you get 400 or 500 people, Indian people, coming together in the urban area. Very rare. There are no urban neighborhoods here. People come to the health centers, to Friendship House events, to hang out with other Indians. And that's where you make connections. You hang out with people. Oh, yeah, a counselor that you might have had several years ago. You say, well, yeah, my son's not doing so well. Maybe we'll set up a treatment. Maybe we'll set up a session. You know, so it's a way to connect. There's a drum. There's prayers. There's always an Indian flavor to these events. Then as you go up the hierarchy, case management is for people maybe who are still using, who can't make a regular commitment to once a week counseling session, which is our next level. And at this boundary here, you open up a treatment plan, you open up a client file. Then your outpatient counseling at the Family and Child Guidance Clinic, mental health, substance abuse, co-occurring disorders, and then your gold standard in treatment, drug treatment, your residential, 24 hours a day, 7 days a week. It's the most effective substance abuse treatment provided by Friendship House. Very, very difficult. Family and Child Guidance Clinic has blended funding. We have federal money. Most of our money is federal, from SAMHSA Grants and other federal grants. Some Indian Health Service, a tiny bit. Some City of Oakland, and some State of California. We have 11 different contracts we manage at the Family and Child Guidance Clinic. This is almost a nightmare. It's very, very difficult. SAMHSA, our growth, when I started working, we had about 10 years ago, $150,000 annual budget. Now we have a $4.3 million annual budget. It was a little higher. Now it's coming down a little bit because the funding cuts on federal, state, and county levels. We had a max of 45 staff. Now we have about 28 staff. SAMHSA grants, 21 SAMHSA grants since 1998, from Center for Substance Treatment, CSAT, CMHS, Mental Health, and Prevention. The CSAT grants, we've had 3-year grant, Native Men, focusing on Native Men, TCE HIV, Treatment Capacity Expansion HIV, Native Women, Native Youth. Friendship House has had a 5-year grant focusing on homeless natives, and another 5-year on criminal justice, reentry from the criminal justice system. Our CMHS grants have been the Circle of Care, which Janet King was our project director, which was a planning grant, and Urban Trails, which is a 6-year grant to develop a system of care, implement a system of care for Native American families and mostly disturbed children. We're just ending that in a year and a half from now. And Native Circle, which is a very grant, was a brilliant design developed by Nelson Jim to do mental health services for Native Americans with HIV. Our CSAP grants are Native Voices, which is a prevention grant, and One With All, which is a remarkable grant. It's called Strategic Prevention Framework State Incentive Grant. Our urban program became classified as a tribal organization. So we're able to receive state funding. And this grant is a prevention grant in a coalition with Northern California urban programs, including Sacramento Native American Health Center, Indian Health Center, Santa Clara Valley, and the Friendship House. We've also had other funding, federal funding from CDC, the Circle of Healing, Office of Minority Health, called Shake the Feathers, which is a coalition of with the Native American AIDS Project and the Bay Area American Indian Two-Spirits. HRSA, we've had some SPINS projects, special projects of national significance research grant. One was called the Holistic Native Network. That was a 5-year grant that's completed. And currently we're on Project Hope, which is a dental services research grant. Total federal resources since 1998, $25 million. Our evaluation, we worked on data from 536 men and women using the GIPRA instrument, the CSAT. Serena Wright, raise your hand, as our Director of Research and Evaluation. We finally have someone who can research all the information we have in our database. And again, we have outcomes, drug and alcohol use down, criminal behavior down, enrollment in training and school increase, and employment increase. Okay, now need for a holistic approach. And this is heartfelt. It's something that I worked on in my mind and wrote a little about before I started working with Native communities. The social service delivery system is so fragmented. You have funding from substance abuse, mental health, poverty, education. It's fragmented funding. And the whole system is fragmented. The whole system does not really work. You also have institutional-based diagnosis, which means a kid who's using drugs gets arrested for smoking pot, and so he's diagnosed as a drug abuser. If he acts out in school, he has a learning disorder or is emotionally disturbed. So the institution that picks up the behavior is the one who does the institutional diagnosis, and that person gets services within that system. Different clinical philosophies in all these areas, lack of cross-training. Clients are integrated, the systems are not. Clients perceive themselves as whole people. If I had to demonstrate 4 elements of the holistic model that we utilize, is self-help, empowerment, culture, and building a healthy community. Self-help, you're taught to help yourself, basically. You take responsibility for your own behavior. Empowerment, you feel empowered to lead a better life by yourself or in a support group with peers. Culture, you got to bring in the culture, and perhaps more difficult to is you got to build a healthy community. And that's where Western science, scientific method has gone astray, has become too reductionistic, too narrow-focused. You need to build a healthy community. This model we developed, myself and Janet King, over 10 years ago, and this was very resourceful because we got a lot of resources, a lot of federal money behind this. Basically, you're looking at the creator in the center, and then your basic elements, your healing elements, air, water, the earth, the sky, the herbs, the food. These are healers, which are addressed in Native ceremonies. And then you have like a next circle, sort of a Jungian way of looking at the human being, dividing into 4, the spirit, the thought, the emotions, and the body. So you're looking at the whole person, basically, not just the thought. You're not just doing a cognitive behavioral approach. And then you have the green circle is all the symptoms: poverty, homelessness, mental illness, substance abuse, physical illness, domestic violence, dysfunctional families, emotional disturbance, learning disorders, victimization. These are all symptoms, okay? And the institutions are geared to treat the symptoms, not the prime cause. And when you're looking at primal causes, we heard about historical trauma. We're talking about being out of balance, imbalance. The society, Western society is out of balance. Families are out of balance. The individual is going to be out of balance. So what kind of healing technologies, what kind of healing methods do you use to get back in balance? To heal one's own life traumas, historical traumas, to heal the community. So the solutions are stuff that we've used and tried at different communities. Positive parenting, communication skills, ceremonies, Native American church, Red Road, Sweat Lodge, talking circles. These are all solutions that there's clinical evidence that have worked in communities that have the resources to do these kind of programs. You also look at housing projects, wellness education. And the outer circle are the institutions that impinge on the individual and their families. Now, linking treatment, prevention, and recovery is an interesting thing here. You want to look at this model here. This is the links. And you're looking at the link between treatment and prevention is early intervention. The link peer support is the link between treatment and recovery. Recovering individuals serve as role models. Culture and spirituality build a strong and resilient foundation for recovery. Okay, so you want to look at where these domains intersect. It's in the middle, which is the community, the culture, the spirituality. You can do all of these programs, evidence-based practices, wellness education, HIV prevention, mental health, substance use, medical treatment, recovery support, housing, employment, life skills, and giving back. But you need a cohesive community. What we found out in the Bay Area is it just starts with one person in recovery, and then 2 people, and then 3 people. And the Friendship House, starting in the 1960s, has provided that recovery system, the Recovery Community Support Network, for many, many years. And so now there are thousands of clean and sober Native American Indians who serve as role models for the kids growing up on the street. That's how it works. You build a healthy community, clean and sober events that people come to and hang out. Cultural program, powwows, traditional healers, sweat lodge, talking circle. We use the Gathering of Native Americans. Theta came back maybe 8-10 years ago, did a training for trainers, and we've implemented that over the years. The Gathering of the Lodges is a yearly event. We have inviting lodges, drug programs, clinics from all over California come and celebrate recovery. July 25th, you're all invited. Lenny Plenty Hoops raise your hand, has got flyers. There's Lenny, he's got flyers, and it's a free event, and it's a celebration of recovery. You got 400 or 500 people there. Okay, now evidence-based practices. You look at, I go through the literature because they're now making funding dependent on evidence-based practices. So where are they about Indian people? They're really hard to find. American Indian Life Skills Training, developed by Teresa Laframboise. It's for a captive audience, school-based Indian children. Motivational interviewing, there's some manuals out. And again, it's like motivational interviewing, I think, is a good intervention. You listen, you don't judge, you support change, but it's like a 2 to 4 session intervention. And short interventions, brief interventions, do not work to address the amount of trauma, feeling, and emotion in Indian people today. Then you have positive Indian parenting, which is developed by Terry Cross and NICWA, National Indian Child Welfare Association in Portland. And this is structured, but it's a very, very good, tailored to Native people. No data. There's very little outcome data, very little control, randomized data on these, and a holistic system of care, which we're in the process of documenting the effectiveness. Now, we talk about community healing. Okay, you have community versus individual intervention. It's a community intervention. So how do you measure change? How do you measure impact on the community? Very difficult, especially with current scientific epidemiological tools. Then you have, and I think this is the biggest issue which we need to address, the funders, the resources, the academics, Western scientific method versus indigenous worldview. These are worlds apart. Indigenous worldview has to do with relationships. It has to do with the connectiveness. Western scientific method is reductionist. It's based on separation of variables. There needs to be an acknowledgement all across on the value of indigenous practices, because there's no data, there's no collection, academics don't know about it, funders don't know about it, but there's a big value in these practices, and that's the work of this conference today, is to promote the value, to show the value. Now, post-colonial psychology was a concept used by Eduardo and Bonnie Duran in the 90s, was a book written, and it talked about the impact of colonialism on Indian people, basically. And it was a very important book. Now, it was too threatening for the mainstream because it was very political. It was very, very political. You don't want to face, there's a dominant culture, and then there are other subcultures. Okay, then Maria came along with the concept of historical trauma. And that was a beautiful concept, a very brilliant concept, because what it did, it took colonialism and the impact of genocide and years, hundreds of years of oppression, and talked about that in mental health and psychosocial terms. So you were able to bring the political impacts, the political effects of colonialism into how it impacted Native people historically and contemporaneously. So historical trauma was a real great concept. And at some of the CSAT meetings, you had people from the Latino caucus and the Black African American caucus kind of questioning Native American people on their concept, because they were beginning to understand Western psychology was not impacting their people, basically. So you began a beginning of a movement to develop and acknowledge indigenous practices, cultural programs in all of these, with all these ethnic groups. When you take historical trauma among Native people, you also have to look at slavery and the impact of slavery among African American people. You have to look at the impact of immigration and the immigration issues on Latin American people. And immigration is such an issue. I mean, the first Americans were here. People in Latin America, Indian people, were here. It was the Europeans, the Caucasians, who were the immigrants. So you really have to look at all of those things. If you really want to heal substance abuse, mental health, you have to address social issues. Okay, winding up, epistemology is the theory of science that investigates the origin, nature, methods, and limits of knowledge. How do we know that we know? Okay, I'm for an indigenous epistemology. Scientific method that is basically used is evidence-based practices, random clinical trials, pre- and post-tests. What about practice-based evidence? Clinical evidence of these approaches have worked in Indian communities for many, many years, talking circles, ceremony, sweat lodges. What about social consensus as a way of knowing something works, something's true? People, we agree around, we sit around a circle and we say, yeah, this works. And what about wisdom of the elders? You know, I mean, our ancestors have done this. Our elders basically say, this is the way things are, this is what we need to do. These are as much valid, in my mind, as scientific methodology. Okay, there are a lot of contradictions. How do you measure community impacts? Okay. The exclusion of minority populations in development of evidence-based practices. Evidence-based practices versus consumer input. They want consumer input, client input into treatment and programs. What clients say in 10 years is we want food, we want ceremonies, we want traditional healers, we want cultural practices, we want transportation. This is what clients say. They don't know about evidence-based practices. Okay, I think the biggest flaw was linking funding to evidence-based practices. I mean, when they made, SAMHSA made funding linked to evidence-based practices, when there are very few, if any, evidence-based practices that are validated in Indian communities, that was an exclusionary method. It also publish or perish, which was the theme in the academic world. To survive, you had to publish a paper. They're now applying that to nonprofit community-based organizations where you have to publish your data in order to get funding. Bad impact. Bad impact. And then the manualization. This one, I agree. Manuals for talking circles? I mean, you have ways of teaching that are mentorship, that are oral, that are practice-oriented. You don't just read a manual and do something. Okay, and where does the future lie? The validation of indigenous systems of care, multi-ethnic and multi-tribal realities in Oakland, in this world, an alliance between researchers, scientific researchers, and tribal organizations. This is the key thing. This is the message of this conference. We need resources for documenting the effectiveness of indigenous programs, and we need a dialogue. How can we help each other? Okay, this is a slide of a book that me and Mary Phillips edited, Healing and Mental Health for Native Americans, available at Altamira Press. Some references. and that's where you can get a hold of me. Thank you.